Some very good news from a late-breaking clinical trial here from the CoreValve Extreme Risk trial, and we're talking about the rate of stroke, which is probably one of the complications most concerning to surgeons like the guy standing next to me. And in this whole area, stroke is a huge issue, and that's where some of the good news is. I'm with Dr. Michael Reardon of Houston Methodist DeBakey Heart and Vascular Center. First off, thank you very much and congratulations. This looks like a great trial.
Well, Rick, thank you. It is a great trial. We've worked very hard. The sponsors put a lot of effort to make sure this is a very rigorous, data-intensive trial. We think we've got some great results that are going to really be good for the TAVR community and our patients in general.
You enrolled a lot of the patients in this trial, so can you tell me a little bit about, first off, who are these extreme risk patients?
Well, the short answer is these are people I would not operate on as an experienced surgeon. I've looked at them and I said there's a greater than 50% chance that you'll either die or you'll be permanently disabled if I operate on you at a 1 month period. So I would never operate these people. Now, one of the very interesting things is that Partner B actually randomized against medical therapy. It's the only randomized trial. It's the only one we'll ever have. The results were so outstanding, the FDA would not let us randomize. So we chose a very conservative and very rigorous objective performance criteria, basically taking the 95th% lower level against the medical therapy of Partner B and said, we've got to beat that. And we combined that with 5 contemporary balloon angioplasty studies and said, we got to beat that. We beat it substantially. So what we found was a couple things in this trial. First of all, the Partner B trial showed us that transcatheter valve is a reasonable alternative for people that don't have surgical options. And in fact, at 1 year, the number to treat to avoid their primary endpoint of stroke or mortality was 5.5. Wow. We dropped that number, the 33% they saw, down to 25%. Our number to treat is going to be about 2. So we've taken what are already good results and made them even better.
And what did you find in the stroke side of things, which is always an issue?
Well, that's really interesting, Rick, because if you look at stroke, that's one of the issues that got raised after the partner trials, because stroke was about twice as common in the TAVR arm as it was in the surgical arm. We actually dropped the stroke rate to almost in half of what it was in the Partner B trial. And what this looks like, if you look at this group of patients who are 83 years old on average, this is close to what we would expect in a surgical group of patients. So that's really good news, again, for the TAVR community and our patients. We're getting much better at stroke. Stroke is always a concern. We'll continue to work on it, but now it's starting to look more like what a surgical population would be at this age if we were to operate on them.
The outcomes are almost surprising. What's different? How is it that we're able to do this so well? Are we just getting so much more experience doing this?
I think it's a combination of two things. First of all, we are getting more experience. We all learn from the partner investigators, but moreover, it's another device system. There are iterations of these devices. We're engineering the devices to be better. So another area that is fundamentally different from stroke is the leakage around the valve, what we call paravalvular leaker. If you look at the partner trial, we've taken the 1 year paravalvular leak and dropped it almost in half. More importantly, if you look at the paravalvular leak in the partner trial at 1 month and 1 year, it doesn't change. We looked at this in paired analysis, and our paravalvular leak between 1 month and 1 year, 80% of the people got better. The difference is it's not a balloon expandable valve that expands and stops. This is nitinol. It keeps pushing out. The heart remodels over a year, and so it fundamentally gets better. And we also found that the people that had moderate paravalvular leak, it was not a marker in this trial for mortality. So again, good news. We're now starting to get closer to what the paravalvular leaks would be in surgical valves. We'll continue to work on the engineering part of this.
And what was the news from the FDA?
Well, the news from the FDA was great. You know, typically, as you know, these things come in, they want to subject it to a panel to look at this, and then that starts another 180 days before they think about it. The FDA looked at this and said, this data is so good, you guys don't need a panel. So the good news about that is it means that we should reach commercialization earlier, which means good news for patients in the United States.
I think it's terrific, and I would hope that the comments that you've gotten since the presentation are pretty positive.
I think the comments are all very positive. I mean, again, people that are interested in taking good care of patients want to see this field advance. And again, we've taken what was originally good data in the partner trial, and we've made it even better. That's good for our patients.
Oh, absolutely. And for Dr. Reardon, the rest of the details on this trial and others can be found in CardioSource World News. I'm Executive Editor Rick McGuire.